Art therapy to enhance nurse wellness is our episode topic. My guest is Craig Menbauman, a registered nurse and Air Force veteran. Craig is our first guest in this podcast series that is leading from the bedside. He's currently a stretcher-side emergency nurse in the New York City metropolitan area. We met last year through his participation and my attendance at an event called the Nurse Antigone Project. Craig is a member of the Emergency Nurses Association, Sigma Theta Tau, and the Greater New York City Black Nurses Association. A quick additional disclaimer before we get started that Craig is not speaking on behalf of the Nurse Antigone Project or Theater of War Productions. And with that, let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Shimolewski.
Hey Craig, how are you?
Hey, Nick.
Let's jump right into it. Can you tell us a little bit about your journey towards an interest in art therapy and your journey towards the Nurse Antigone Project?
I'm a military vet. I was in the Air Force. I was a medic for 6 years. Then I went and got my political science degree, after which I realized, yes, I want to change the world through political science, but it's not rejuvenating to me. So I needed that hands-on experience. I wanted to be both in the world of I wanted to be at the cross sections of making long-term impact, but also responding to urgent need. So I said, let me get myself back into nursing. And I am in love with everything that I'm doing. I connected with Brian Dories, the creative director of Theater of War, and now the Nurse Antigone Project, back in 2017 over a project he was doing that focused on veterans. You'll see why I'm bringing up my veteran experience momentarily. After leaving the military and after graduating with my first degree, I realized that I needed my own healing from my veteran experience. And so I found myself in a lot of art spaces, a lot of humanity spaces, from poetry to acting to using Shakespeare to artistry. A lot of different variations of art therapy is what helped me to move on from my trauma that I carried from the military. And now when I came into the field of nursing, already being linked to these therapeutic models, already being linked to Brian. And it was happenstance for me that he was creating a program to look at what was going on in the aftermath of the pandemic for nurses. And I just happened to also be a nurse by the time this project came into being. And so he was like, you've been with us for the veteran stuff. Let's do this nursing stuff together. And so there's still a lot of questions around it. How do nurses come to even recognize that well-being is something that would benefit them? I've done a lot of thinking around it, and I also lead with more questions than I do answers around this concept. Using art therapy to heal and process events that need processing. I have seen it in the ER in the short time I've been there. I've seen it across the profession of nursing in my coworkers. What I'm seeing often is we're really good at putting the care out there towards everything external towards us. When it comes to turning it back in, there's this block, and I don't exactly know where it comes from. I have a few hypotheses that it may come from. Maybe the people who get drawn to nursing in the first place are people who are trying to fix something about themselves, but find that it's easier to project it and fix it outside of us first, always compartmentalizing whatever it is internal for us.
Yeah, I'm really concerned about our well-being moving forward. And I think part of it is evident just by the drones of the number of people that are leaving the profession. Some are leaving because they've had it from a work-life experience and they're just done, and others are just emotionally gone. And how do we take care of these people
not necessarily at a global or even at a national level, but okay, I'm the CNO at a small community hospital. What are
Mhm.
some things that I can do to take care of people? And how can I leverage, to your point, art therapy as a means to promote healing? What would that look like at a hospital level? Because I think for the Nurse Antigone Project, it really was a lot of people self-selecting themselves in, and certainly you probably would want to continue to self-select, but the safe space of going through that therapeutic experience or that milieu certainly
Mhm.
probably changes when you shift it to I'm now in an environment where the people that I'm around and I'm with are the ones that I also work with. In some
Mhm.
spaces, that may be a better therapeutic experience, and in others, it may not. And how do we leverage that? What does that look like? What are your thoughts on that?
Number one, there has to be a recognition of the power dynamics at every level of the game. The power, and we like to say there's no hierarchy, but there's a hierarchy. And medicine functions in a hierarchy, especially in hospital systems. Specifically for CNOs and nurse executives, they have to recognize that I think that even as much as they may want to connect with and level with the nurses who are at the bedside, fundamentally there is a power differential between those two individuals. And what that in my experience, what that always means is that you will say some things to your colleague who's working the floor with you, and how you speak to your colleague is going to be always different from how you speak to your CNO. And I think one of the best things that could be implemented, this is coming off the top. We need culture keepers, right? Because I thought about this as I was working. A culture keeper is a person who works the floor alongside, they're in the rank and file, and they're, I guess they have an elevated perception of how the events that are happening on the floor impact the mental and emotional capacity of their coworkers and can call a timeout and say, we need to check in about this thing. I would say culture, having at least one or two culture keepers per shift who can check in for those big moments, that's already a really big start. I'd say that censoring the nurse's experience and allowing there to be an understanding of the amount of information and input juggling that we are doing on any given day, and how we're stuck between these two spaces where on one hand we are centering our patients' experiences and trying to give them what they need, responding to their requests, their demands, their gripes, their complaints. But on the other hand, we also have to respond to the requests, demands, gripes, and complaints of the providers. And being able, we are almost like in electricians, there's this thing that creates when you have too much electricity coming in one way and you need to slow it down coming out the other. We're almost that intermediary thing that controls the high demands that are coming in from above us and filtering it down so that it doesn't hit our patients. I think about this concept of talk about trickle down economics. Well, I think there's trickle down pain as well. When someone said it to me a couple of years back, they said when the father hits the mother hits the child kicks the dog, right? Pain tends to trickle down. And so I feel like so if there is not respect coming from the top down, then what you have as an alternative is pain coming from the top down, a lack of respect coming from the top down, taking for granted the work that nurses are doing from the top down. So I think fundamentally there needs where for those CNOs, for those CNEs that are interested in trying to get to a space where their people feel comfortable speaking to them about their experiences, because I think that's the start of it. Being comfortable speaking to the people in positions to do something about improving your situation. And there's already a gap in that communication.
Let's take a step back for a moment. What exactly is the Nurse Antigone Project?
Oftentimes, people who are experiencing trauma, the parts of their brain that allows them to communicate is shut down or weakened or diminished in some way, shape, or form. But their ability to acknowledge things is not. And so when you give them a thematic play, right, in theater where we're using Antigone, a play, it could be a piece of poetry, it could be an excerpt. But for theater of war, we use a whole play. When you give them a play where they can see themselves, when you give them the opportunity to just sit back, watch, they will begin to project what they are experiencing onto the characters in the play. And that gives them this more safe modality to revisit their own experiences and then speak to it in the aftermath once the play is done. So theater of war is a space that allows people to safely revisit their own experiences and speak to them without judgment.
Wow. What has your experience been with the participants being frontline bedside nurses versus nurse leaders? Because I know a lot of the productions were done within the nursing leadership community. I'm wondering how many bedside nurses had the opportunity to go through that experience.
I don't know if I can answer that question. I
Okay.
think that, some of them, they didn't necessarily feel like in one event that their experiences were necessarily being reflected.
Okay. So let me ask you this question then. If I'm a nurse leader in a hospital and I'm trying to figure out how to take care of my staff, and I understand that disconnect that exists or can exist despite the best of intentions on both ends, just from the power paradigm, so to speak, or the power structure that exists. One might suggest one appropriate solution to that would be to set up the experience, but not have leadership be present. The
Yes.
downside to that is we're really talking about, while we're creating a safe space, we're also segregating to some extent. And while there may be therapy there that exists, is there an opportunity for leaders to learn how to better support their staff and what the true issues are that come out of it? I guess what's the risk benefit there? What are your thoughts on that?
My gut response to that is nurse leaders have to realize that it's not about them anymore. Like, it's not
Yeah.
about when you're in a lead. To me, right? I'm coming from the perspective of leadership is an important word for me coming from the military. I'm open to be proven wrong, but if you're in a position of leadership, then you have a mission to accomplish. And if you're going to lead people towards that mission, that means that mission is worth accomplishing without you being there. So that means that you have to empower people beyond yourself to do this thing if you were to be absent from it. And so if we were to create a nurse Antigone or a safe space for those file nurses, those on the ground nurses to have their voices heard, those nurses didn't create that segregation. The segregation already exists by the power dynamic. We're just by creating in this hypothetical scenario, by creating a space for the on the ground nurses, the bedside nurses to get their voices heard without being encumbered or feeling in any way watched or observed by people in positions of leadership. You're elevating their voices, but that separation, those bedside nurses didn't create that. That's just an inherent separation that's created by the hierarchy of hospital systems. That's not to say it's a good or bad thing. Neutrality here. That's just saying that segregation exists. If we don't acknowledge that, then we can't even begin to approach resolving the issue if we can't acknowledge the differences in that.
Yeah. What you're saying, though, actually is very consistent with an earlier episode that I had with Pam Thompson, and that who's the CEO emeritus of the American Organization for Nursing Leadership. And then also Eric Martin last year, who's the current president of AONL. And they have a fellowship program that brings together leaders from across the country. And one of the key tenets of that program is actually creating a safe space for learning, right? So that these managers or directors that are new to their role or growing in their role have a place where they can explore concepts without fear of retribution. And what you're discussing is really nothing more, at least in my mind, than providing a therapeutic environment that's the same, only really at the bedside level.
It
Go ahead.
also doesn't have to be either or. We don't have to work from a deficit framework that if we have this, then we can't have that. We can have both. We can have this therapeutic space for the bedside nurses. We can have a cohort of nurses in leadership positions, and then we can have them merge together. It doesn't have to be either or. I reject that completely, that we can't have both. We can have both. We can make space.
Talk to me a little bit more about adding value.
That's the most important thing to me, that wherever it is that I go, wherever it is that I am, that I can leave there saying that I've done a good job and maybe even left the space a little better than I found it. That's a core value of mine, to be able to add value to spaces, places, and people. So I don't have all the words to express the gratitude I have for you even mentioning it. As I said, I'm new to the profession, but I want to see where it can take me, where I can take it. I've always said that I will invest in an institution that invests in me. And while nursing is an institution, it's a profession. The profession is investing in me, and I will be invested in it. I'm a nurse through and through, and I'm here to do what I can to improve what we do.
Any closing thoughts around therapy, art therapy, theater therapy for bedside nurses and the value that it brings to the nursing profession?
Yeah, therapy, art therapy, the humanities. It reconnects you to your body, fundamentally so. It connects you to the most authentic version of yourself because to be able to produce art, good art, right? And that's not even the focus, but to be able to be in that space where you're producing something artistic, even without judgment of what the outcome is, you're not selling this product, you're just producing it for self. It brings you back, it reinvites you to in metacognition, in self, in introspection, you tap back into who you were before the traumatic event that happened to you. And when you can connect to yourself like that again, it makes you a better nurse. Because fundamentally, as human beings, I think that one of our most important drives is to be in community with each other. And you can't be in community with another person if you can't even be in community with yourself. I think about my baby that was just born a week ago, literally a week ago. And the euphoria that I experienced of seeing her. And while it isn't art, it is therapeutic. The sunlight feels sunnier. The wind feels windier. All of my feelings feel so much more palpable. And what it has already done for me, it has expanded my capacity for empathy for other people. And even when I see people on the street, I see them, I see myself in them again. That's what art allows. At least it allows me. It has in my life, it has allowed me to do that, reconnect with myself for the purpose of then being able to reconnect with others.
Craig, thank you so much for taking the time to talk with me today. I think you've given a lot for all of our nurse leaders that are listening to this podcast episode to think about how do we enable some type of platform like this for our frontline staff in whatever organization they're in. Thank you so much.
Of course, my pleasure. Thank you for having me with us.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.